Now we are going to discuss most prevalent and most important cause of female infertility, that is the ovulatory dysfunction. And we know the ovulation is dependent on various factors. We already know that the primordial follicles, they are in finite number, and they are uh, present already at the birth of female in her ovaries. So it is a limited stock. It could be depleted, or it could not grow to become Graafian follicles. So there could be various reasons that these primordial follicles, they won't grow. And they we know they have a 70 days growth before they comes under the influence of LH and FSH for their final maturation. So that 70-day maturation is dependent on various growth factors that are present in ovary. So if there is a problem with those growth factors, then these follicles, they cannot grow up to the uh, mark. So they cannot undergo, they cannot develop receptor for LH and FSH, so they cannot be converted into Graafian follicles. So there could be certain other causes, like we know the ovarian and the uterine cycle, they are uh, supporting each other. They are superimposed, they are running side by side. So they are dependent on various hormones that are coming from the hypothalamus, pituitary, or from the ovaries themselves. So we know at start we need FSH to grow these follicles. So if FSH is not present, and why FSH would not be present? If there is a dysfunction in the availability of FSH from gonadotropes, release of FSH from gonadotropes, could be any dysfunction in FSH itself, could be a dysfunction of receptors. We know the granulosa cell, they have receptors for FSH. If these receptors are not in proper shape and form, they cannot respond to FSH. Similarly, there could be uh, deficiency of GnRH, or GnRH receptor would be uh, defected. So uh, it cannot grow granulosa cells, cannot convert androgens into estrogens. So there would be no growth of primordial follicles, and there would be no uterine cycle as well. Similarly, if LH is not present, it means its receptors, its hormone, the protein itself, and the GnRH, if they are not coming at the certain frequency. We know for for LH, GnRH should be in faster frequencies. It should be having short duration to be released, that is short wavelength, we can say. So if the frequency of release of GnRH is not up to the mark, LH could not be released, and only FSH would be released. So there would be uh, no formation of estrogen, because the estrogen always required androgens, because estrogen are converted from they are aromatized form of androgens. So if androgens are not there, then the estrogen cannot be formed. So there would be no ovulation, there would be no follicular growth, there would be no ovulation. So the uh, LH receptor on theca cell, they, if they are affected, there would be no uh, effect of LH on the primordial follicles or the theca cell. So Then if the receptors for the entry of cholesterol into mitochondria to undergo in the formation of the androgens in theca cells and conversion of estrogen in the granulosa cells. So these receptors, if they are not proper, then there would be no ovulation, because we know for ovulation there should be a peak of estrogen, and then uh, there would be a peak of LH in response to that estrogen peak. So if estrogen is not present, then there could not be a peak of LH. So there would be no ovulation. There would be no even growth of follicles. So it is most of the time hormonal causes that are helping ovulation, and if there would be a defect in these hormonal regulation, there would be defect in ovulation. So we'll see these all factors one by one. In ovulation dysfunction, we enlisted hypogonadotropic hypogonadism as the first cause. So it is due to isolated hypogonadotropic hypogonadism, or it could be Kallmann syndrome. So we know what is hypogonadotropic hypogonadism. It is the low levels of LH and FSH due to deficiency of GnRH, could be due to the malfunctioning of the receptors that are present on the gonadotropes in pituitary. So we are well aware about this topic, that is Kallmann syndrome. So it is having same effect that it is having in the uh, male for spermatogenic failure, or we can say testicular failure. So here it is the ovarian failure, mean there would be no growth of the follicles, and there would be no ovulation, there would be no uterine cycle. So ovarian cycle and uterine cycle both would be affected. So so we would go toward the second cause, that is the PCOS, polycystic ovarian syndrome. Polycystic ovarian syndrome is also called as Stein-Leventhal syndrome, that is from the two gynecologists who described this first time, discovered it. So polycystic ovarian syndrome is actually the formation of a lot of small cysts in the ovaries. So ovary appears, it becomes bigger in size, its volume is increased, and then it is also appearing like a having a lot of cysts, small cysts in that are actually the a lot of follicles that could not ovulate, they could not grow properly, they could not ovulate. So we'll see what are the causes of this polycystic ovarian syndrome. The obvious features of PCOS or polycystic ovarian syndromes are infrequent menses, that are the menses are only uh, coming after 3 months or 6 months or more, and there could be obesity. The body weight is more than the optimal levels. That could be measured by body mass index, and we know body mass index is the ratio of weight to height. If body mass index is over than 30, then it is classified as obesity. So if a female is obese, having infrequent menses, and has hair growths on upper lips and chin, that is called as hirsutism. That are the hairs that are androgen dependent. We know these hairs on lips and chins, they are only present in males because they have androgens, a dominant hormone in their body. So these hormones, these follicles, these hairs and their follicles, they are sensitive to androgens. So it means there are a lot of androgens in females, and they are causing these hairs to grow in females also. Then there is another uh, feature, that is dark velvety pigmentation, that would happen on most of the women in at the nape of the neck, or there could be under armpits, and could be uh, anywhere like on the thighs, and it is called as acanthosis nigricans. This acanthosis nigricans is a depiction of uh, insulin resistance. It means these females, they would have are going to develop diabetes mellitus. So these four features, if they are present in a female, we can suspect her for polycystic ovarian syndrome. Her ovaries may have developed the polycysts, a lot of cysts. So infrequent menses, obesity, hair growth, that is hirsutism, dark velvety pigmentation. PCOS are characterized by presence of excessive androgens due to, most of the time, due to lifestyle, that is the overweight or obesity. So here we see the how androgens get in excess in women. That story started from accumulation of a lot of adipose tissue. If a woman become obese or overweight, that is body mass index is over than 25 or is more than 30 for obesity, so these women, they may develop insulin resistance. So these fats, if they are more in body, they would not allow insulin to act on its receptor. So body needs more insulin to perform its function. So there would be stimulation of the pancreas to make more insulin, and that condition would be called as hyperinsulinema. Hyperinsulinoma mean the insulin concentration in the blood would increase than the normal. So this hyperinsulinoma, it would affect on the ovaries, and it would uh, cause the thecal cells to make more androgen. It would affect on thecal cell, and thecal cell would respond more to LH, and they would produce more androgens. So these androgens, their level would become high in body. So this is the positive feedback mechanism. Obesity is causing insulin resistance. Insulin resistance is causing hyperinsulinoma, and hyperinsulinoma is causing thecal cells to make more androgens. At the same time, this hyperinsulinoma is acting on liver, and it is affecting liver to uh, release less sex hormone binding globulin. Sex hormone binding globulin are the globulin, these are the protein that get bind to steroid sex hormones, estrogen, progesterone, and the testosterone and other androgens. So this sex hormone binding globulin, it is formed in liver. Why the sex hormone, they need sex hormone binding globulin? Because they are steroid in nature, they are lipid in nature, they cannot travel in plasma, that is a watery medium, because they are hydrophobic. They need an associated protein to get travel. So this sex hormone binding globulin also keeps the levels of sex hormone in blood in check in normal concentration. So in a normal body, a normal human being, 80% of androgens, they travel bound to sex hormone binding globulin. They are bound to sex hormone binding globulin. Only 20% are others. From these 20%, 90% are bound to albumins, and 1% is only free in plasma. So it is a delicate equilibrium. If this 1% would enter into its destination into cells, we know these are steroid, they would enter into the nucleus of the cell, and their receptors are in nucleus, so they would be depleted, and then more androgens they would get free from sex hormone binding globulin. So sex hormone binding globulin would act as a store of androgens. If sex hormone binding globulin would decrease due to hyperinsulinoma, then androgens, the free androgen, they would become more. They are not now 1%, they would become more. So androgen would increase in the body. Also, when this androgen it enters into fat tissues, it is converted into the androstenedione. It would be converted into testosterone, and then testosterone it would in adipose tissue it would be aromatized to estrogen. So estrogen levels they would increase. These estrogen levels they would become chronically increased, mean their high levels would be sustained for all the time. So they are not like in normal menstrual cycle we saw the estrogen they increase gradually, then there would be a peak, and then there would be ovulation. So in this case the estrogen levels they are continuously high. So these continuously high or chronically high estrogen levels they would decrease, so they would give positive feedback to LH, and we know when estrogen are in higher levels they would uh, produce a peak of LH. But in case of normal ovulation, there would be gradual increase of estrogen, then there would be a peak of estrogen, and at that peak there would be a peak of LH that would result in ovulation. But here the estrogen levels they are continuously high, so LH would also be continuously high. There is no peak, it is chronic increase in LH, and then this estrogen it would give negative feedback to FSH. So FSH levels would be decreased, they would remain low all the time. The increased level of androgens, they in turn would increase adipose tissue, they would increase the insulin resistance. That would cause more hyperinsulinoma and would cause more development of the uh, androgens in thecal cell. So this is a vicious cycle, a positive feedback mechanism. A change is increasing the change. Androgen production of androgen is increasing more production of androgens. So this is a cascade. It is a positive feedback mechanism that is regulating it. So there would be increase in androgen in the body. Now we know that excessive androgen would be responsible for PCOS. How they would affect follicular growth, and they would chronically elevate levels of estrogen, a form of estrogen that is estrone. How would they do? We know in theca cells there are in the follicles, theca cells of the follicle, and there are LH receptor. These LH receptor they would bind to LH, and cholesterol would enter into the theca cell, would be converted into androstenedione, and then these androstenedione they would seep into the granulosa cell where they would be converted into estrone. The first step is that the androstenedione it would be converted into estrone. So that is called as aromatase activity. There is an enzyme that convert androstenedione into estrone. So the then this estrone is converted into estradiol under the influence of FSH. So here are two other enzymes that are converting estrone into estradiol. Estradiol is called as estrogen, or it is called as E2. Actually, it is estrogen we know is a larger class that has three hormone in it. That is the estradiol, it is the estrone, and then is the estriol. So androstenedione in is directly converted into estrone. So if it is being done in the theca cell normally, then the estrone would be converted into estradiol. Most of the estrone would be converted into estradiol. So estradiol level would be more in blood than the estrone. But in case of insulin resistance, there would be, uh, we know, the androgens, they would go back to the adipose tissue where they would be aromatized. They would be converted first into testosterone, and then they could be converted into the estradiol. And these androstenedione, they would go into adipose tissue and also would be converted into estrone. So it is peripheral conversion, it is non-regulated type of conversion of or aromatase activity. So it is not regulated. It means most of the estrone would not undergo the conversion into estradiol. So estrone is E1. So this E1 estrogen, it would be more in body because the cells that are in periphery, they are not regulating it. They are just converting androstenedione into estrone directly. So in case of uh, polycystic ovarian syndrome, if androgens are more, then they would be converted in adipose tissues, they would be converted into estrone. So estrone levels or E1 levels would be increased in the blood. So these estrone, they are also estrogen. So they mimic like the estradiol. So they would mimic estradiol, and they would act on the pituitary to give positive feedback mechanism. Their levels are high because they are being converted in adipose tissues from androgens. So their levels are high, so they would increase the, we know, in case of normal menstrual cycle, the at day 14, near to day 14, before day 14, we know there is ovulation at day 14. The cycle is of 28 days. So near to day 14, 1 or 2 days before, there are elevated levels of estrogen. From where estrogen is coming, we are talking about normal menstrual cycle. It is coming from the granulosa cells of the Graafian follicle. So these estrogen, they are increasing along the maturation of the Graafian follicle. So Graafian follicle are the follicles, they are being matured, and they are gradually increasing release of estrogen. So at near to ovulation, the estrogen levels, they would reach to peak. So this peak, normally estrogen give negative feedback mechanism, but when estrogen levels, they become high at a certain level, they would give positive feedback to pituitary. So pituitary would release more LH. Here we can see a peak of LH. So there would be a peak of LH that would cause the ovulation. So in case of PCOS, because the androgens are more and they are being aromatized in peripheral body, independent of the growth of the follicle, it is being converted into estrone, that is type of estrogen. So estrogen levels, they are generally high, they are near to this surge, they are chronically high, they are high all the time. They are independent of the growth of the follicles. So these high levels of estrogen, they would go to pituitary and they would result in positive feedback mechanism to LH. So LH level would remain high all the time. There would be no peak like here. You can see at here in polycystic ovaries, there are at day 14, there is no peak for ovulation. So there would be no ovulation. That is called as anovulation. And this anovulation would result in, we know, a lot of primordial follicles, they are recruited, and then they would be only one of them would be converted into dominant follicle, and then it would become Graafian follicle and then would ovulate. But if there is no uh, growth of these follicles, they would not be converted into any one of them uh, could not be converted into the dominant follicles or into Graafian follicle, these all would regress. They all would die. So these dead follicles, they would stay in the ovary. They would add up in the ovary. They would become part of the ovary permanently. So the ovary would appear as polycystic. If we see ovary through ultrasonography, it would it would appear as having a lot of cysts in it. So these cysts, they are called as polycysts. So that is called as polycystic ovarian syndrome. So ovaries, they would increase in their size due to the addition of these cysts. So ovary size or volume would also be increased. So anovulation due to hyperandrogenism in PCOS would affect menstrual cycle, and there would be delay in menses. There would be no ovulation, so there would be no ovum released into the fallopian tubes, and there would be no fertilization. There would be infertility, and we know there would be no corpus luteum formed because no ovulation would occur in the PCOS. Normally, after ovulation, there would be progesterone, and this progesterone, it stabilizes the proliferative uh, uterine endometrium and convert it into secretory form. But when there is no ovulation, there would be no corpus luteum, there would be no progesterone, and there would be no stabilizing effect of progesterone on the uh, endometrium. It would keep on proliferating. It would remain always in proliferative form. So it would be growing, and it would called as endometrial hyperplasia. That is the abnormal growth of the endometrium. So it become thick, and there would be no shedding of this endometrium because there is no uh, dip down of any hormone, that is estrogen, and it is always in proliferative form due to high levels of estrogen. So the after that, the endometrium, after some time like 3 or 5 months, it would outgrow of its blood supply. We know there are blood vessels that are coming into the from myometrium. These blood vessels, radial blood vessel, they are entering into the endometrium into basal form and then into the functional uh, process of the endometrium. So these blood vessels, they are now they cannot support these endometrium that have grown a lot. So these endometrium, they would shed off, and then there would be breakage of these blood vessels, and there would be bleeding. That bleeding or that menses would stay for longer than normal, that is 4 to 5 days. They would stay for 10 to 15 days, and they would come after 3 months or 5 months or 6 months or later. So their frequency is less, and then this an ovulation, it is a delaying cycle that would be called as oligomenorrhea. Oligomenorrhea mean less number of cycles per year. So then the normal. So there could be amenorrhea. Amenorrhea mean absence of the menses at all. So the anovulation or the high levels of androgen, they would cause the delayed cycles, oligomenorrhea. They would cause infertility. They would cause endometrial hyperplasia, and they would may cause amenorrhea. That is no menses at all. Diagnosis of PCOS is done by using Rotterdam criteria. There are three criteria, and if two of three are present, then we say the PCOS would be would also be present. So these include abnormal menses. If a woman has amenorrhea, that is absence of menses, or oligomenorrhea, that is less frequency of menses than the normal, and we can say delayed menses. And then there could be hyperandrogenism, increase of androgen hormones in the serum, or could be also appearing the signs of the hyperandrogenism. So this could be clinical or it could be biochemical. So if it is clinical, it means the phenotype or the appearance would be like hirsutism, that is the growth of hairs on lips and chin. And then the biochemical could be presence of serum testosterone when we test it by using a certain technique like ELISA and RIA. So then the third criteria is ultrasonography. If uh, ultrasonography is done, then there should be at least 12 cystic follicles present in the ovaries. Here we can see normal ovary and then the cystic ovary. So these 12 follicles, they should be 2 to 9 millimeter. And then there could be another thing, that there would be appearance of necklace on the ovaries. Here normal ovary it is not present, but here we can see a band. So this band would include at least 12 follicles. And then another thing is the volume of ovary should be more than 10 ml. So if only one ovary is suspected to have polycystic ovarian syndrome, then it is uh, suspected to as the polycystic in other ovary also. So these criteria, if two of these criteria are present, then normal menses, hyperandrogenism, or the uh, 2 to 9 millimeter regressed follicles present in the ovaries, one of the ovary, then the woman would be diagnosed to have PCOS. And however, 25% of normal women that are not appearing to having hyperandrogenism, they have normal menses, and even then they have the cystic ovaries. So there could be certain other hormonal changes like uh, serum testosterone, other androgens like androstenedione would be high, could be LH. If we test LH, it would be high. We saw the estrogen, the chronic increase in estrogen in polycystic ovarian syndrome would chronically elevate LH. So the ratio of LH to FSH would become 2:1, and the serum, uh, that is the sex hormone binding globulin, they would decrease, and total estrogen would be increased. Other hormones, they would also be affected. We can see higher levels of testosterone, we can see higher levels of androstenedione, we can see higher levels of LH, chronically higher levels of LH, because the chronical high level of estrogen would cause LH to be high all the time. So then the LH to FSH ratio would increase to 1, and normally it is 2:1, but it would increase then 2:1. LH would increase more. And then the total estrogen, they would increase, and again the estrone concentration would increase than estradiol. In case of PCOS, estrogens are more than estradiol. E1 is more than E2. But in case of normal ovaries, the estradiol is in serum, estradiol would be more than estrone. but here it is reversed. Estrone would be more than estradiol. And then sex hormone binding globulin, they would be lower. FSH, due to negative feedback of estrogen, it would be lower than the normal. Various other conditions like hypothyroidism and adrenal hyperplasia, they have same symptoms as that of PCOS, so we have to be careful for diagnosis of PCOS. We have to differentiate it from the other disorders like hypothyroidism. It is the low levels of thyroid hormone. They would decrease GnRH levels. They would also decrease the sex hormone binding globulin, and they would end up in an ovulation or infertility. PCOS, we know, chronic high estrogen, uh, they would cause an ovulation. And then in adrenal hyperplasia mean the adrenal gland, the cortex, it is making steroid hormones. So these cortex, if the number of cells increase in this cortex, there would be more androgen in the body, and these androgen, they would ends up in an ovulation. So we have to make a differential diagnosis. We have to check whether thyroid hormone is low or not. We know that if we test TSH, its levels are high. It means T3 and T4 are not present in normal levels. So we have to determine it. Similarly, we can determine the adrenal hyperplasia through ultrasonography and through the hormones of the androgen hormone that are coming from adrenal uh, gland, that is DHEA. We have to detect it. So after that we can be certain about PCOS. Management of the PCOS mostly include the changes in lifestyle. They would decrease obesity, and we know the obesity and lifestyle, they are also related to diabetes mellitus or insulin resistance. And the weight loss is responsible for resumption of the ovulation or the ovarian function. So 5 to 10% of weight loss in women that have PCOS would resume ovulation. So treatment of PCOS in women would be asked whether they want to conceive or not. So if they don't want to conceive, or they are of underage, they are unmarried, then they would be uh, placed on oral contraceptive pills. The oral contraceptive pills that have estrogen and progesterone in them. So they would be given for 3 weeks of this weeks, and then they 1 week would they would not be given. So they would have effect on ovarian cycle or ovarian hormone. They would have effect on uterine cycle. They would have certain other characteristics. So for ovarian effect, the estrogen in pills, they would give negative feedback to pituitary, and they would lower LH and FSH. So there would be no follicular growth in the ovaries because LH and FSH would be lower, and then the ovaries, they would become functionless. There would be no dominant follicle, there would be no Graafian follicle, there would be no ovulation. So the ovaries would become dormant, and then the uterine cycle, it would also be affected. For 3 weeks, the pills would be given that have estrogen and progesterone. So the estrogen, they would grow endometrium, and after 3 weeks and 4 weeks, the pill would not be given. At that time, this endometrium, due to absence of estrogen, it would shed off, and then there would be so it is like normal menses. And menses would be normalized; they would become cyclic, and then there would be other effects like they would regularize menses, as we saw. 3 weeks growth of endometrium, 1 week when pill is not given, endometrium would shed like normal menses. It would prevent endometrial hyperplasia. Hyperplasia means overgrowth. So endometrium would not overgrow, it would shed. And then it would decrease hirsutism because estrogen is present in the pills. Estrogen in pills also increases sex hormone binding globulin that would lower androgens because androgen would bind with sex hormone binding globulin. So these effects they would bring the ovaries back to their normal cycle, uterine walls to normal function. So these pills they would be given for longer time. If the women they don't want to conceive, they would be given for a year, for 6 months or more, and uh, then if the women they want to conceive, they are married, so they would be given drugs to reduce ovulation. So they would be most of the time aromatase inhibitors. So these aromatase inhibitors, they would lower the levels of chronically high estrogen that are present in PCOS. So there would be less effect on the FSH, negative feedback on the FSH. FSH would come and then there would be start of follicular growth. So there are certain drugs like clomiphene, citrate, and letrozole. They are the aromatase inhibitors. They would be given, and then there are uh, methods to control insulin resistance in these women because insulin resistance it is causing the leptin mellitus and also the increase in androgen. So they would be given drugs like metformin, that is the drug for diabetes. So they are going to decrease the insulin resistance. Then another method is surgical method, that is to do laparoscopy to uh, drill the ovaries and to release the stroma or the tissue of the ovaries that has the cyst in it because it is producing high androgen. So to decrease that tissue to lower the androgen levels.